I will be talking on septic arthritis in children, right? Okay. To start with, I think when we talk about septic arthritis, it always almost being referred to as infectious type of arthritis, right? Bacteria is always the main cause, while others such as fungus or viral can be also the causative organism. Almost always, septic arthritis will be bloodborne, and usually it involves the large joints, especially the knee and the hip. I would say that actually in children, the hip are more common to be seen, and in adult, I think the knee will be more common. And in terms of demographic, it will affect mainly the young child as well as elderly. But last but not least, the patient that who are immunocompromised, such as diabetics and those with autoimmune disease. Okay, the pathophysiology, I think this picture just to show you on how the hematogenous spread coming to the joint, right? The most common way of getting septic arthritis, sometimes we get a direct inoculation from a penetrating trauma to the affected joint, and occasionally we can also get a direct spread from adjacent bone, especially in cases of metaphyseal osteomyelitis, right? This is just to show an example of a child who actually presented initially with a flexotenosynovitis, but end up also to have a septic arthritis of the hip, and this is the most common way of spreading of the infection to the blood supply. Okay, in terms of microbiology, all right, commonly I think based on the age, you can have different type of organism, but mainly you can see we are getting it from the gram-positive type of organism. For example, in the neonates, Streptococcus is more common. As a child get older or the person get older, Staphylococcus aureus start to comes in. Haemophilus influenza has been used to be common previously, but I think slowly being eradicated following the vaccination program, right? And I think the atypical organisms start to come in cases where actually patient who are IV drug abuser or patient with sickle cell anemia, and last but not least, I think nowadays people start to talk about Kingella kikei as the emerging pathogen among the pediatric population. In terms of clinical presentation, I think being a septic arthritis, sepsis infection in nature, I think the presentation will always present, patient will always present with form of fever. The fever is usually of high grade temperature. Because of that, they will also present with chills and rigor. The patient appear lethargic. And one of the most important clinical signs that we can see in septic arthritis will be pseudo-paralysis of the affected joint. The joint will be very painful, especially when we attempt to move the affected joint. The joint is swollen and the skin overlying the joint is also warm in nature. Okay. When we talk about diagnosis as well as investigation in septic arthritis, I would say that actually it should be diagnosed mainly by clinical assessment. Septic arthritis must be being diagnosed through clinical assessment. If we perform joint aspiration, all right, that will be diagnostic, and by sending the aspirated fluid for culture and sensitivity, that will be confirmatory for what type of organism that we are dealing with. On top of that, we may be able to do some form of blood investigation as well, where we look for the raised white blood cell, raised in CRP, the inflammatory markers, ESR, as well as the sending the blood for culture and sensitivity. Okay, we talk about radiology. All right, I think radiograph will be the mainstay, but radiograph might not be able to tell us much, especially in the early part of the septic arthritis event. What we can see in the radiograph could be just a widening of the joint space. Ultrasound may be of helpful. MRI has been done, but I think in our setup, MRI is a bit difficult to get, as well, especially in children where you need to put the patient under general anesthesia. One form of investigation that I think nowadays people start to forget to ask is actually gram staining of the specimen, right? Okay, based on the clinical as well as the investigation that we send, I think culture criteria is one of the important criteria that we look for. Initially, culture give us 4 criteria, which mainly the temperature, the inability to bear weight, the ESR as well as the total white blood cell count. And the prediction shows that actually if we have, and each parameter will be given a point, and of the, if we add all together, the likelihood of the patient to have a septic arthritis is very high. And I think Kate et al. Modified it by adding CRP. It become another predictors, and this is called the modified criteria. But having said so, if we add all the criteria, it just help us to say that actually the likelihood of patient to have a septic arthritis is very, very high. Okay. Okay, just talk a bit on the management. I think the mainstay, not the mainstay, one of the important management in septic arthritis is the use of antibiotics. We may start the antibiotics as empirical, but once we get the culture and the sensitivity, we may change it to therapeutic. And I think most of us here have the antimicrobial guideline based on the hospital or the national needs. I think in Malaysia, I think this is the guideline at the moment for septic arthritis, right? Based on the possible organism. The cephalosporin is of choice, especially the first generation and the second generation, which is cephazolate as well as cefuroxime. The duration is always debatable, but I think nowadays is almost agreeable that for septic arthritis, the total duration of antibiotic prescription will be about 3 to 4 weeks in total, right? In terms of administration of antibiotics, the intravenous antibiotic will be given until the patient what we call that start to improve. Mainly they become afebrile, the inflammatory markers start to normalize, and then we can change it to oral antibiotics to be completed as per duration by the guideline. The mainstay, I think, will still be surgical drainage. The main reason why we need to drain the septic joint is because the product of the white blood cells that actually produce all the chemical mediators that may damage the cartilage. So we need to clear up the joint. For the large joint like the knee, we can join the joint lavage. In the adult, we may do it arthroscopically, but I think at the hip, especially in children, we may need to do an open surgical drainage and performing a hip joint arthrotomy to clear the affected joint. Okay. Okay, to go to an example of a case, I've first seen the case quite some times ago. This was actually a 2-year-old boy who actually was referred to our center following a history of fever, and then refused to walk with a swollen thigh, but complaining of like a knee pain. Right, so you can see from this referral, he started with just a dry cough, and what you call that, start to see general practitioner, but was given medication, but came to us about 6 days after the onset of the event. Okay, so this is the child. You can see how painful or how miserable the child is, and you can see also actually the right thigh here is swollen and actually is held in flexion, which is the position of comfort for any joint what you call that, joint pain. So I think looking at this with the joint swelling, pseudo paralysis, as well as the clinical features of inflammation over the affected side, and on top of that, the patient is having a high temperature, I would say there is no doubt that actually this child is having a septic arthritis of the right hip. Okay. Following which, we did some blood investigation. The total white was 23, the ESR was 109. We did blood culture. Somehow rather the blood culture result come negative. I think from the literature, we do know actually the blood culture is not so sensitive. I think only up to 50% that can get a positive result from blood culture. But if we were to take the blood culture, it's most important that we take the blood culture during the peak of the febrile event. Whenever patient had a spike of temperature, so that will be a good time to take the blood culture. But as we saw, I think in children it's not that easy for us to take the blood culture. Okay, so a radiograph, you can see actually the joint space on the right side here. There's haziness as well as abnormality, but if we are not familiar with this type of so-called radiograph, we might miss this, right? And we might not actually think that actually the joint is actually having some problem. Okay, we sit the patient for ultrasound, and you can see the ultrasound from the right femur, the right hip joint. There will be increase in the joint space as compared to the left side, and this is reported as well, where actually the joint effusion is being reported, and that's where the limitation of the ultrasound, right? The ultrasound might always tell us whether there is a effusion or not. Some may report of periosteal elevation or debris in the joint that's suggestive for septic arthritis, but it's also mainly depends on the person who's doing the ultrasound. So at the end of the day, I will say again, all the investigation, the blood investigation as well as the radiological investigation is an adjunct to help us to diagnose septic arthritis, but the diagnosis of septic arthritis remains through clinical assessment. Okay, so this is the child in the OT. The hip is in flexion FC, and we did an anterior approach for the hip joint to drain, and therefore straightaway pus coming out from the hip joint. Okay, we did a joint lavage, and we following which I think we close the skin. Nevertheless, what I've learned from this case is that we started this patient with cloxacillin initially, because we thought actually the most common organism is still Staphylococcus aureus. That's why we start with cloxacillin. And nevertheless, 2 days after the first drainage, we got pus pouring out again from the hip joint, and we have to go in again and clear the joint again. And if you notice, the color of the pus that coming out from the affected joint here is not so yellowish. I think that actually gives us an indication that we might not actually be dealing with the Staphylococcus, the typical Staphylococcus aureus, where the pus usually is quite golden yellow in color, right? And true enough, actually, when we send it for culture and sensitivity, the organism that we get is actually Streptococcus pneumoniae, which is sensitive to amoxicillin clavulinate and resistant to the cloxacillin, right? So this is a child after antibiotics, after we changed after the second drainage, after we changed the antibiotics to amoxicillin clavulinate acid. I think by almost 2 weeks of IV antibiotics, the child started to be favorable, and you can see here he is more comfortable. What's so special about this child is that 6 months before this event of septic arthritis, this child had a cochlear implant implanted at his temporal bone, and the cost of the cochlear implant is 60,000 ringgit. And just imagine if we do not tackle the septic joint aggressively, it may actually, cause problem to the cochlear implant. Okay, so there you are. So this is the intraoperative II images to check the stability of the joint after we do the drainage, and you can see the joint space here is much reduced. And this is the X-ray 3 months after arthrotomy. Again, you can see the Shenton's line is broken. Most probably this indicates some damage to the epiphysis. As we follow up this patient further, this is 9 years after the drainage, and you can see this patient in this Ortho long leg radiograph. There's a limb length discrepancy between the right lower limb to the left lower limb. I think this patient last seen about 2 years ago at the age of 12 years old, and he has about 3 centimeter limb length discrepancy. However, the range of motion is quite acceptable. I bet there is an limited abduction, as you can see from this radiograph. And we did suggest and offer the patient regarding contralateral hemiepiphysodesis to catch up the limb length discrepancy, or we might do a lengthening procedure if there is a need. But I think the patients are not ready for that procedure, so he just being treated with a shoe raise. This is another child presented to us with 3 centimeter limb length discrepancy post septic arthritis, and this is from another view when he is get older. On the right side here, you can see the Trendelenburg, all right, following the septic arthritis, and this is the outcome of the septic hip. This patient actually was referred to us from somewhere else with this type of problem where the right hip is already dislocated, yeah, and this is the range of motion that we have, almost quite acceptable. And this just to show you on the possible sequelae of septic arthritis in a child. So in the first case, you can see the hip joint is actually still stable, but in the second case, you can see the head is gone, the hip dislocated, and the right hip joint that is actually become unstable. In terms of management, I think this is a good article that everyone can read. It was published quite some time, but I think it's still relevant. And when you talk about the sequelae of septic arthritis in a child, the Hyomka classification is always being referred to, and it's based on the what you call that, the outcome of the septic arthritis itself, whether the hip is stable or the head is gone, that making the hip joint very unstable. I think Prof. Choi from Korea also modified the radiographic classification based on the hip deformity, and I think Prof. Choi classification does help in terms of determining what type of surgical procedure or management that can be done, right? And one of the procedure that can be done would be actually trochanteric arthroplasty. If the greater trochanter epiphysis is still available, we can do a varus osteotomy and put the greater trochanter back into the joint and make it functioning like a hip joint. To be honest, I myself personally, I haven't not done this procedure. Maybe the seniors like Prof. Lee and the others might help and advise us on this type of procedure. Another late construction procedure that can be offered to this type of problem in patient with septic arthritis would be the pelvic support osteotomy. This is a bit complex procedure. I've only done it once, and I think personally to say that actually performing a pelvic support osteotomy, the outcome is quite favorable to the patient as well, where they get back the limb length discrepancy, the proximal femur is quite stable, and they can almost like functioning near to a normal person function. Okay. The others I think we can do, it would be some sort like hip arthrodesis if there is need to. But last but not least, I think at the end of the day, just like the patient in second case, the patient does not want anything to be done. All right, so I think the patient now is already 18 years old, so he managed with the limb length discrepancy that he has, offered PSO, but the parents, I think, and the patient himself, I think, are not open to that type of procedure yet, and they are happy with whatever that they are now. Okay, so at the end of the day, I think whatever that we have from the sequelae of the septic arthritis, the management will much depends on the functionality of the patient as well as what does the patient want. Okay. Take home message, I think septic arthritis is always an emergency, especially in a child. The diagnosis is mainly clinical. That management includes the use of antibiotics as well as surgical drainage. Our aim, especially in the hip, is to get a joint stability, and late reconstruction of the hip joint will be an option if patient requires any intervention. Okay, I just want to share with everyone here from the AOA. This is our new UKM Children's Hospital, right beside the current HUKM. Inshallah, we'll open it up by next year. We actually started operating somewhere in March, but because of the pandemic of COVID-19, the hospital has been changed to manage a totally Cat 4 and Cat 5 COVID-19 patient for almost 4 months. But I think hopefully by next year we can open up this hospital. Just to share that we have the facilities of hotel here as well as convention center. So maybe if we can do something, we can invite everyone from the AOA fraternities to have some form of meeting here in this new hospital. That I say thank you very much.